Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. As doctors, we're taught to do no harm, but sometimes what some may consider harm can be much better for a patient in the long run. That's the case for one of our guests today, and we're going to meet her in a moment. We'll also be checking in with Dr. Dana Hawkinson. Our COVID numbers, they took a jump this week. But let's start with the historic news regarding a new gene editing treatment in today's morning rounds. Last week, the Food and Drug Administration approved Exa-cel to treat sickle cell disease. Actually, they approved 2 drugs, so we're going to talk about that in just a moment. Exa-cel uses a gene editing technology called CRISPR. And you may have read there was an article in the Star yesterday about it too. We're going to explain in a moment. It was actually published in the New England Journal a couple of months ago. The FDA just got around to approving it. And while it's not a cure in a small clinical trial, patients with either of these therapies saw their symptoms disappear. I'm going to turn now to Dr. Joseph McGurk, who's much more fluent in this than I am. He's the Division Director of Hematologic Malignancies and Cellular Therapeutics. Okay, that's a lot of words. We just say HMCT. He is the head of this. He's developed our whole entire bone marrow transplant program. Amazing person. He thinks, I think, that this is also incredibly exciting for patients. Dr. McGurk.
Absolutely. Thank you, and good morning, Dr. Stites. This is an extraordinary time for patients with sickle cell disease. And just as a little background, sickle cell disease is a genetic inherited disorder. It affects about 100,000 people in the United States, predominantly African Americans and Hispanic Americans, lesser so. And it's a devastating disease. It's a disease where the gene abnormality creates a protein called hemoglobin that is misshapen and carried by red blood cells, normally taking oxygen to our tissues. This abnormal protein, hemoglobin, from the genetic abnormality causes the red blood cells to form sickle shapes, and they plug up blood vessels. When they plug up blood vessels, they cause tissue injury and severe pain crises in patients. It's a terrible, debilitating disease associated with very significant pain and suffering for patients and a shortened life expectancy. And today, there are curative therapies. We have long-term follow-up of stem cell transplant using someone else as a donor, although access has been problematic for affected patients. And now, this really stunning development of genetically modified stem cells taken from the patient to the laboratory, modified, expanded, infused back into the patient that create a normal, healthy hemoglobin for patients and can stop these painful crises, the organ damage that are caused by these painful crises. Casgevy and Lyfgenia are the 2 constructs. They use a little bit of a different strategy for genetically modifying the stem cells that create the red blood cells that carry the hemoglobin and oxygen to the tissues. And our center is one of the first centers in the nation to be offering a gene-modified therapy. As Dr. Stites mentioned, there are 2 such therapies currently available, a little bit different than each other, but both directed at the same end outcome for our patients. Most importantly, we really need to get the word out to the African American Hispanic community for the affected people. This is not a very rare disease. 100,000 Americans are affected, as I mentioned, yet many do not know about it, are not aware, and need to be educated. So we have a lot of work to do to make sure we get the message out there.
You know, Dr. Burke, this is my career as both a lung doctor and an intensive care doctor. We would see patients with this, and so many of them are young, and it is just a tragedy because the pain is real. The insult to the body is real because when you don't get blood to the joints or to the heart or to the lung, you cause tissue damage and tissue death in those areas. And eventually it can be so debilitating people die from it, as you mentioned, at a very early age. What I was reading is that this therapy is it's curative. I mean, the results are impressive with both either choice of treatments.
Absolutely. That's exactly right, Dr. Stites. The overwhelming majority of patients, 95% engraft these cells and the stem cells that have been genetically modified in our patient are effective in producing adequate amounts of this these other types of hemoglobin, two different types, hemoglobin A and fetal hemoglobin, depending on which construct we use. And that has mitigated or completely alleviated for the overwhelming majority of patients also the symptoms, the veno-occlusive crises that these patients suffer from, the associated pain, and God willing will be life-prolonging and lead to a normal life expectancy for such affected patients. We don't know that yet. We don't have long enough follow-up. It is a rigorous process. These gene therapies still require stem cell transplantation because you take the stem cells out, genetically modify them, and then infuse them back into the patients after chemotherapy. So it's a challenge, but as you know, our center is one of the largest stem cell transplant programs in the nation, and as I mentioned, one of the first to offer this therapy. But again, if people don't know about it, then it doesn't do them any good. So we intend to meet with leaders of the African American and Hispanic communities in our metropolitan area, across our state, and throughout our region, because we will be one of only a few centers, particularly in the Midwestern part of the nation, to offer such therapy.
And I understand that therapies are going to be inordinately expensive, so we're going to have to work closely with insurance providers, government, and other groups to make sure that these things get approved. But I've heard it's over $1 million for a treatment course. Is that what you're hearing as well?
Yes, $2.2 to $3.1 million. So they're different costs. There has been an ICER, which is a complex equation that looks at life years saved with therapies, a mathematical strategy by MIT that has demonstrated that this appears to actually be cost-saving in the long run because it significantly decreases hospitalizations and complications of sickle cell disease in patients. But it is a very significant upfront cost. In contrast, I came from a meeting in San Diego just this past weekend, American Society of Hematology, where Vanderbilt presented their data update on stem cell transplant using somebody else as a donor for patients with cost about $200,000 to $400,000, also demonstrated to be a curative therapy for a significant percentage of patients, and the majority of those patients being cured of their disease long term. And so the bottom line here is these gene-modified constructs, one of which is the first to use this gene editing technology in a human, and being the first to be approved such therapy by the Food and Drug Administration in the United States. These constructs can be life-saving for our patients. But we have to look at these cost issues and think about the other type of stem cell transplant using somebody else as a donor. If that's $200,000 to $400,000 and with the same outcomes, which was presented this past weekend, versus gene therapy, we need to have that conversation with the patients and their families, and insurance carriers will discuss that around the country, which is a more cost-effective strategy, but effective strategy. So our patients with sickle cell disease, bottom line, have options out there, different risk-benefit profiles, different cost profiles, et cetera, but it's an extraordinary time for patients with this terribly debilitating disease.
Yeah, for sure, and we'll get you back on the program. I want to talk to you. Make sure you come back, bring one of your patients with it once you get one of these new therapies, and let's go back to it. So you tell me when we do, is we want to have you come back, because this is an incredibly pivotal moment in the history of medicine to modify genes, your own genes, give them back to you corrected so you don't have the disease anymore. We can't emphasize enough. This is one of those true inflection points, and it is a remarkable time to be in medicine. Thank you, sir. Thanks for coming.
Yes,
today,
thank
sir.
you. It is a revolutionary time. Thank you for the opportunity.
You bet. Speaking of revolutionary times, as I mentioned at the top of our show, we are pleased to have Lisa Connor join us this morning. With her is Dr. Lindsay Kilgore, a breast surgical oncologist at the University of Kansas Cancer Center, and Dr. Laura Nye, no relationship to Bill Nye the Science Guy, who's a breast oncologist at the University of Kansas Cancer Center. Welcome to you all.
Thank you.
Welcome.
Thank you.
All right, Lisa, I understand that you did not have breast cancer per se, but your grandmother, aunt, and 3 cousins did. So you decided to have yourself tested for a genetic defect that can cause increased incidence of breast cancer, the BRCA gene, also known as? BRCA gene. All right. So talk to us a little bit about that.
Yeah, so It was a little unexpected. I actually have two grandmothers that had breast cancer, but late in life, so it wasn't necessarily expected to be genetic. But when I connected with some cousins that I hadn't talked to in a long time and realized they had breast cancer, I talked to my gynecologist at the time, and she was like, we need to test you, make sure there's not something we should scan for. And I think we were both surprised when I came back positive for the BRCA2 gene. I was in a situation where I was 53 years old, I had 5 children, and I was, at this point, I just wanted to spend my life with my kids. I also knew there was a possibility that I passed this gene on to my kids. 2 of my kids are girls, and I wanted to make sure that I modeled what I would want for them. They're going to have some choices to make depending on where medicine goes in the future, but I wanted them to know how I did this. So I chose to have a hysterectomy very quickly and then worked with Dr. Nye and Dr. Kilgore to do a mastectomy this past summer.
All right, so we're going to get to that point, but I want to talk to Dr. Nye for a moment and say, talk to us a little bit how genetic testing has evolved, and what is this BRCA, whatever gene, what does it do?
So BRCA was one of the first gene mutations associated with cancer that was discovered. And just over a decade ago, that's all we tested for was BRCA1 and BRCA2. But now we can test for a handful of breast cancer genes as well as hundreds of genes associated with an increased risk of cancer. And it's become much more accessible, meaning that cost has come down from thousands of dollars to hundreds of dollars, and it's covered by insurance, as well as simpler. So we could do a blood test or a saliva test. Many patients are getting this through genetic counselors or with their primary care, or OBGYN is what we commonly see. And it can be life-changing to get that information and know your cancer risk and know that there's actions that you can take to reduce that risk.
You know, Lisa, armed with this knowledge that you had the BRCA gene, you had some choices. You could do nothing, or you could get surgery. And ultimately, you decided to have both your breasts removed, just like Angelina Jolie a decade ago. Talk to us a little bit about how you made that choice.
Again, it comes back to family. I was pretty comfortable with medical terminology, having worked in drug development, and my husband is a physician. So I was not intimidated by the process itself. I'm pretty pragmatic, so I just wanted to have a life that I didn't have to worry about. I felt like I was waiting for breast cancer to appear because my risk was so high, and I wanted to eliminate that. So again, it goes back to my family. I wanted to spend time with them, and I didn't want to spend time with them as a sick cancer patient if I could help it. And at the time, I had a 7th grader. So I was thinking I was waiting for a cancer diagnosis while she was in grade school or high school, and it just made sense to me.
So Dr. Kilgore, women with either a BRCA1 or 2 mutation have a very high risk, and you can actually kind of help us quantify what that risk is like. There's both breast and ovarian cancer. Sometimes you have to recommend both breast removal and ovarian removal. Talk to us about the absolute risk and how often you see that you have to go ahead and take both breast
so
and
we know that you have increased risk of breast cancer as well as ovarian. Breast cancer risk is higher than the ovarian cancer risk, but depending upon if you have the 1 or 2 mutation, you have a higher risk of ovarian cancer. We really look at patients' family histories, so do they have more ovarian cancer risk or breast cancer? When we're deciding the order, should you have your hysterectomy first, like Lisa did, or should you proceed with mastectomy? What risk is higher for that individual when we counsel on how we should proceed with which surgery?
And it's harder to find ovarian cancer than it is breast cancer in many ways, so it's sometimes I know that leans into that decision. So is this risk, like we're talking about, 10% over a lifetime, 50% over a lifetime for breast cancer? Tell us a little bit about that.
It can be anywhere upwards 50 to 60% lifetime risk of breast cancer.
That's a lot of risk right there, huh? And ovarian, which again, probably a more devastating disease in some regards, therapy's not as good. often found in later stages. That's a pretty high risk. I think, is it like 20 to 40%?
Yep, depending upon if you have the BRCA 1 or 2, it's anywhere quoted 20 to 40% risk lifetime of ovarian cancer.
And maybe even pancreatic cancer as well. So these are not things to take lightly, and it's really important. Dr. Kilgore, how common is it for a patient to choose a double mastectomy? It's a big surgery.
Yeah. You know, it is a big surgery, but like Lisa said, you know, for the right people, it's the right decision. Because during that mastectomy, we're removing 95+% of all the breast tissue, and therefore giving those patients a 95% risk reduction. And by choosing that mastectomy, they're choosing to be proactive in their cancer care, and like she said, not waiting for a cancer diagnosis. And by being proactive and doing that surgery, although a big surgery at the time, you're decreasing your risk of going through chemo, radiation treatments. Also, you know, you decrease your risk of lymphedema, because if you do it prophylactically, we're not removing lymph nodes. And lymphedema can be a side effect of cancer treatments. And so women that take that step, although it's a big step to take, are very happy with the results usually in the end.
So Lisa, how was your surgery for, and what was your recovery like?
I would say the first 6 weeks, like any surgery, you're slow, you're groggy, you're kind of wondering what you got yourself into. But again, I was like, I did this for the right reasons.
You did it for the rest of your life.
Right, right. And I also did it, like I said earlier, to model for my daughters that this can be done and it works. I remember having a conversation with my then junior in high school and trying to explain all this to her, because it's a heavy topic. And she had seen friends whose mothers had had breast cancer, so it was scary. And she very quickly said, if it's going to keep you healthy, then go ahead and do it. It was very simple to her. So that's kind of how I feel.
And just to say briefly, so I'm going to jump to you for a moment, but BRCA 1 and 2 have implications for men as well.
That's correct.
So talk to us a little bit about some of the risks for men.
BRCA1 has a high risk of breast and ovarian cancer, but we're starting to acknowledge the pancreatic cancer risk. BRCA2, though, also has an increased risk of male breast cancer, prostate cancer, which we're also starting to be suspicious of with BRCA1, and then skin cancer, melanoma. And so when we counsel patients, I counsel men and women on their risk of breast cancer as well as other cancers that they need screening for.
So you really have to make sure men at a certain age actually start getting mammograms, if I remember with this.
There are starting to become guidelines to acknowledge the risk in men, and men do have breasts. That's usually the biggest hurdle we have to overcome in clinic. And actually mammography is very sensitive in screening male breast tissue. So it can be right for the right individuals. The other big thing that we need to get through is that men pass down the mutation just like women do, and it can be inherited from your mother's side or your father's side, and that's something that's really hard to get across in the population.
Yeah, it's a darn big deal. Dr. Kilgore, Lisa wasn't done with when her mastectomy was complete. She had a newer kind of reconstruction called a deep flap. That's DIEP, deep inferior epigastric perforator. Like I said, a deep flap. I've heard one patient describe it as getting a tummy tuck and using that tummy tissue to build new breasts. Easy to say, but I think it's pretty involved.
It's a very intense surgery, but it is an excellent surgery, and we're very lucky to have highly trained microvascular plastic surgeons here at the University of Kansas that can offer this type of surgery. You described it very simply, and that's kind of one of the ways I initially propose it to patients, is it is. It's a tummy tuck, and using those blood vessels and reconstructing it up in the chest, so reconnecting the blood vessels, to use your own tissue to reconstruct your breast, so you're not having to use artificial implants. And you have to have very highly trained surgeons to be able to do that, and we're a high volume center here at KU. One of the only ones in the region to offer such numbers and expertise in this area. So, you know, for our risk-reducing mastectomies, we commonly do them together, where we do the mastectomy and at the same time they get that reconstruction. So they're not having to undergo multiple surgeries. So that's what you can do when you're doing it in a risk-reducing manner, versus as a cancer, we can't wait 6 months to treat your cancer to book that surgery out. Right. So when you're doing it for prophylaxis or risk reduction, we can time that surgery to hopefully help the patients with less surgeries.
And do you have to have, is it a multiple stage procedure, the deep flap, or can you do it all at once?
Yeah, so we usually do the risk reduction mastectomy and the deep at one surgery. But like all surgeries, especially more cosmetic, tweaks and tucks can be done. Insurance covers all of those additional things to make sure the patient's happy with their results. So usually it's multiple surgeries in the end, but little types of surgeries following it.
Yep. So Lisa, how was your recovery from the flap?
It's been good. I went into the surgery, I had 5 C-sections and thought, oh, I did this is going to be easy.
5 children, okay, there you go.
It's not the same as a C-section. It's quite a bit more extensive. So I was a little bit surprised by that when I got up from the surgery the first time. But healing has been fine. I mean, it's that rest and exercise component. I'm not very good at sitting still, but the surgery was extensive enough that I couldn't move, so
yeah, you
sitting was
still
good.
For a while. There you go. All right, so Lisa, or Dr. Is Lisa a lot less likely to develop cancer now? Tell us what the risk reduction is actually like, and
Absolutely.
how much do you have to still look for cancer?
Reducing her risk of breast cancer by 95% with the bilateral mastectomy means that her risk of breast cancer is very low, well under the average woman's risk of breast cancer, and we just recommend keeping an eye on her new chest, and she doesn't need mammography or MRI screening anymore. And then with her removal of ovaries, that greatly reduced her risk of ovarian cancer as well. So we'll still recommend skin cancer screening, wearing sun protective clothing, and we may start thinking about pancreatic cancer screening for our BRCA carriers. But otherwise, yes, her risk has been greatly reduced.
So, if, say people don't want to have surgery, and I know in some countries, I think in Europe it's a little bit more to take this different approach, right? But so what do people do if they don't want to have the surgery, and then they have the risk? So how do you prevent the really bad outcome?
So we use screening for early detection. Screening's not going to prevent breast cancer, but the goal would be to detect it early at a stage where we would minimize the cancer therapies that would be needed. And then for risk reduction, we think about lifestyle modifications as well as chemoprevention agents. So we do use medication to lower the risk. Most of those are not as well studied in individuals with a genetic mutation because these drugs were developed long before we had extensive genetic testing. But we do have options to lower risk, and bilateral mastectomy is not right for everybody, and we usually only consider it when your risk of developing cancer is greater than your risk of not. But there's many gene mutations where the risk of developing cancer is less than 50%, and therefore it may not be a recommended surgery to everybody.
So Dr. Kilgore, double mastectomy is not for everyone. Who's a candidate? Talk to us about some of the risks.
Yeah, so when we look at it, just like Dr. Nye said, we're really looking at individual risk. Different mutations carry different risks, and so each patient needs a true risk assessment because it's not just based on the mutation alone, it's based on family history too. And so Dr. Nye's team, and we have a wonderful high-risk breast cancer prevention program here at the University of Kansas, they do a full risk assessment for these patients, and that's when they figure out, is your benefit worth the risk of surgery? Because surgery is not to be taken lightly. I mean, there's risks of bleeding, infection. Obviously, a reconstructed breast is never the same as your normal breast, but for some people, that risk reduction is the right answer. Some people, it's not. Also, we need to take into account people and what stage of their life they're in and when they feel like it's the right time, because it's a big thing to commit to. And that's why if you get in with a high-risk provider, establish your risk, undergo your high-risk screenings, then different ages are right for different people about when they want to take that next step. And we're available to counsel them on those risks of the surgery and the reconstructive process as well.
All right, this is really remarkable. Lisa, you fully recovered. Yep, and you're continuing to get regular exams. What would you say to women out there who may have the BRCA genes?
I think the first thing I would say is I think there's a lot of fear with breast cancer, and I think this is kind of a ray of light in that because they have some choices and they have some ability to control their own history or their own future at that point. So to not be scared, and I think it depends on their age. My daughters are going to be tested earlier just because, so their decisions are going to revolve around childbearing and some other issues that I did not have to deal with. But I think the key is to just not be scared of the information, and it would have been really easy to kind of hide from it.
Yeah, that's a big discussion to have. All right, so this has been a great morning session. But I want you to help send any questions you may have. Use the links on your screen: YouTube, Facebook, the X platform, or email the Medical News Network. We're going to get to those questions in just a moment. Let's check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the Health System. Hawk.
Yeah.
We saw it. We did a jump this week. Talk to us about those COVID numbers.
Yeah, unfortunately, COVID numbers are up to 33. Unfortunately, we have 7 in the ICU as well, so severe illness associated with these COVID hospitalizations. And that's a big jump up from 19 the week before. And of course, a couple weeks before that, it was in the low 20s. So.
And before that it was in the mid-teens. I think what we're seeing is a Thanksgiving effect. It's there was an article I think on the CDC and carried national a little bit. The Midwest right now is a bit of a hot spot compared to the rest of the country, and Kansas, Missouri specifically.
Yeah, absolutely. And I think we are seeing that. I agree with you. I think it kind of started with all of that holiday travel. We knew the virus was out there circulating. I think and as we saw in the past throughout, it does take a couple weeks for it to really circulate further when people are getting ill at those get-togethers, parties, when they're inside doing things, and then it spreads that way. And it just takes a couple weeks to really show that full effect.
I love graphs. We've got a couple of them to show today. The first is a demonstration because we're seeing a rise. This is a total combination of flu, COVID, and RSV. Altogether, we have over 50 patients, or about 50 patients in the hospital with one of those.
Yeah, I think this is a really good graph. This was put together by one of our infection prevention nurses, Melanie McCulligan. And what it shows is that the green is COVID admissions, the orange is RSV, and the blue is flu. So our RSV and flu admissions, while we'd like to see none, they are up a little bit, as you can see when you compare it to those previous weeks in the graph as you're moving from the right, which is the most recent data, on the far right side, to that left side.
So continue really seeing that increase across the country. And if we just look at the COVID admissions, you can see there's a few kids, really mostly adults, again, I think older, but you can see that really, man, it popped in the last week.
Yeah, it's really unfortunate. Hopefully this isn't an increasing trend. I believe we had 50, almost 60 last January. So we are getting to that time point now. Hopefully we won't see that many, but just as you said, we do unfortunately have 2 pediatric patients in there with those COVID admissions. I think it's just, again, prepare, have that plan, get vaccinated, but have a plan. If you do have symptoms, test early. Again, we know influenza is out there as well, so get tested for influenza, but have that plan and talk with your physicians, especially if you can get on that oral antiviral, which will help reduce your chance of hospitalization for COVID.
Yeah, because we know vaccination and Paxlovid all still work for this variant. And so I think it's a really important point, but and you made a great point. 20-25% of these patients are in the ICU. We haven't seen that for a while either.
Yeah, that's really the unfortunate thing. And again, don't know the full demographics, but what we have been saying is that really COVID is more now a disease of the most at risk, and that is those patients with higher age with comorbid conditions like heart disease, lung disease, kidney disease, diabetes, and of course immunosuppression. And
what we know is that 17% of adults have had the vaccination for the booster. That is nowhere near high enough. Right. Yeah. I mean, certainly we saw low uptake last year. We are continuing to see low uptake. And again, if you are at that highest risk group or groups, it is really encouraged to get those vaccines. Yeah. Don't make a mistake and wait, because once you have it, vaccination is not going to help you. And vaccination clearly helps curb death, ICU stay, serious hospitalization. We need people to stay vaccinated. And I would say that we know that there was a lot of still circulation in the summer, although not as much as it is now. And we have probably all heard of people who had the infection in the last few months. We were encouraging those people who had the infection to get that updated vaccine for COVID at about 3 months after that acute infection as well. And that will probably help push you through now the rest of the respiratory viral season to help reduce your risk of further disease. And if you're over 65, there's RSV vaccination, there's influenza vaccination, and COVID vaccination over 60. Don't hesitate. Don't make that mistake. All right, Jill Chadwick has been monitoring our feeds for your questions. Jill, what's going on out there?
Good morning. You guys ask the best questions, but our viewers always have more, and they're wonderful. We do need to start with Doc Hawk for one. Jean is asking, I have a question. Is Pfizer better or Moderna? And when it comes to the latest COVID vaccine, Jean said he saw a Penn University study that favored Moderna, but it is more dangerous in the side effects?
No.
That is probably just a single study. We'd have to look at what they were looking at, what the question was asked, what is the context of some of the results they saw. I'm not familiar with that, can certainly try to find it and pull it and review it. But the recommendation still, Steve, as we know, is to get either one of those. And so they have both. I think we need to have this caveat and precede this this comment with this, is that they have both stood up to post-marketing analysis for safety and efficacy. And both of these vaccines are very safe. They are especially extremely safe compared to if you get the disease itself.
Yeah, I mean, that's the worst vaccine, right? Just getting the disease.
Exactly.
Years ago, or not years ago, it has been years, people are like, well, which one do I get? And we get into this big, long debate, and I'm like, yeah, whichever one they offer you, just take it.
Yeah.
And if you're really nervous, you can always get the Novavax. Just to say, we're not masking yet in the hospital, but we are keeping a careful eye on the number, and some of our individual units have started masking, not only for patient safety, but because they have employees who have been sick.
I think that's the biggest thing, and that is one of the major measures that we can use, this anecdotal data, to identify increased circulation in the community, because we know most everybody is probably not using masking in the community. It's very easy to pick up this infection and disease. And so just what you said, that is one of the big concerns. But I would point out that the infectious disease physicians here at the health system have continued to wear the mask even after masking went away. I think it has helped us in general.
Because the rules of infection control follow you and take care of you everywhere you go.
Yep. As a practice, we've continued. Now, after this respiratory viral season, we can certainly debate and have some discussions with it, but we have continued.
We see our
to
numbers pop over 50 or 60 and have a different discussion. Jill.
Okay, Yin Lang wants to know, we talked about that women who carry the Angelina Jolie effect, that they might have a higher chance of developing ovarian cancer. He's asking, is the risk greater for endometrial and colorectal?
That is a great question, and there is some analysis looking at an increased risk of a rare type of endometrial cancer associated with some of the BRCA genes, but it goes back to that individualized discussion with a gynecologic oncologist about what is that individual's risk of endometrial cancer or other risk factors that would lead somebody to also need a hysterectomy at the time of removal of their ovaries. The colon cancer risk, we still need more data to identify. We definitely see colon cancer occur in our individuals with BRCA mutations, but we don't know if that's correlation or causation.
Okay, I have another question. Is there anyone who is not a good candidate for the DIEP flap, and can you pull the tissue fat from other parts of the body or just the tummy?
Oh, great question.
Yeah, that's a great question. We really have you have a comprehensive consultation with one of those microvascular plastic surgeons, and they do imaging ahead of time with a CTA. So they got to look at the blood vessels that supply that belly fat, because if you've had multiple abdominal surgeries, you may not be a good candidate for the DIEP flap. You may not have blood vessels that can supply that flap that'll recreate that breast. Or depending on patient's body habitus, you may be too skinny and not have enough fat to recreate the size breast that you're desiring either. So our plastic surgeons can do other types of flaps as well. They can do flaps where they get fat from the thighs. They can do additional muscle flaps. Obviously, we try to avoid muscle if able, but that's where you need a consultation with one of the plastic surgeons to figure out what's best for you based on your body habitus, your previous surgical history, as well as what are your cosmetic goals. Are you wanting to be the same size, smaller, or even bigger?
Great, that's good to know. Somebody get somebody some water. Is that Dr. Stites?
I was trying to get him to throw it to me because I could say I
Lisa?
could catch the ball better than some of the Chiefs guys right now. But
Yeah, okay. So, Sharon, listen to this. She says, my mom had breast cancer late in life, and my dad's sister and niece had breast cancer. My cousin was in her 30s when she was diagnosed, and she died of breast cancer. My maternal grandparents died from cancer too. Her grandmother had uterine and her granddad had colon. She said, I've had melanoma, but it was caught early. She wants to know, am I a candidate for genetic testing?
Holy cow, yes. Okay, the panel was unanimous
That's
here.
very similar
Yes.
to mine.
So she should have a conversation with a genetic counselor. We offer genetic counseling via telehealth for individuals that live in Kansas here at the University of Kansas Cancer Center in Missouri. But you should absolutely see a genetic counselor, talk about your genetic risk, and understand that even if your genetic testing is negative, you may still be at an increased risk of cancers that would require increased surveillance.
And you may be a carrier, which means you have to be thoughtful about what you pass on to someone of doing your spouses. I heard you just say that was similar to my story. Tell us about that.
So both of my grandmothers had breast cancer, but late in life, like after age 70. So I never really gave it any thought. And then I had I had two aunts who again had breast cancer, one on either side of one was my mom's sister, one was my dad's sister. But again, they were over 65, and I didn't think anything of it. I actually got the gene from my dad. It has been determined. So, when my cousins on my dad's side, 3 sisters all had breast cancer, that's when this kind of red flag came up.
And so can you be a carrier, or do you have to have 2 copies of the gene?
It is autosomal dominant.
Okay, so it's really not
if
a
you
carrier
are a
question.
carrier, then you will likely manifest the
disease.
phenotype, the disease. There are some genes that would have a more toxic trait if you were a carrier of 2 mutations.
Okay.
Okay, just a couple of more questions. Ginny wants to know, is there anything in general that women can do to just lower their risk of breast cancer? And I think specifically, if you carry the gene, is there anything you can do? I mean, besides what we're talking about today.
So in terms of lifestyle modifications, which we recommend to everyone, it is exercise, limit alcohol, healthy body weight. Those are the 3 things that have been shown to lower a woman's risk of breast cancer. Exercise goal is 180 minutes a week of aerobic exercise, less than 3 to 7 drinks of alcohol. More than 7 significantly increases the risk of cancer, but really any amount of alcohol does have a risk with it.
Okay, and last question. I'm going to take 2 of them, Sharon and Ashley, and kind of put them together. They want to know, when do you do the DEEP? Do you do it the same time that you do the surgery and you just go right into the reconstruction? And are there nipples?
Yeah, these are all great questions. And that's why when we do it for risk reduction, so we also offer deep reconstruction for our cancer patients, and that's more in a delayed fashion where we put placeholders in at the time of the breast cancer operation, and then in the future when treatments are done, they go back for their final reconstruction, which can be deep reconstruction. Otherwise, if it's for prophylaxis or risk reduction, then we can do it at the same time of the surgery, but each patient case is different. Some women, if they want the surgery now, we can do the surgery within weeks, put placeholders in, and then schedule that bigger surgery out when it's more convenient for their lifestyle to recover from that bigger operation. Those deep operations are in high demand, and so sometimes they can book out 6-9 months, and so that's why we can do them together, but sometimes we also assess if someone needs that risk reduction now, or depending upon their life and what's going on with that, delaying that deep reconstruction for the future. I do want to also point out, just to have a risk-reducing mastectomy doesn't mean you have to undergo reconstruction. Reconstruction is a very big commitment, usually entailing multiple surgeries, and so some women undergo risk-reducing mastectomies but have an aesthetic flat closure. So we as our surgeons will do that as well, making sure that they have a flat closure that they're happy with, and then if they want to wear a prosthetic or something like that, they can or not.
All right.
Hey, just
Jill.
a thank you from Sharon. She said, thank you so much for answering my question. I'll get in touch with the genetic counselor, and I have 4 sisters who will benefit from this information too. So thank you.
Awesome. Y'all be in touch with those genetic counselors. So this has been a really remarkable program this morning. And Lisa, I'm going to turn to each of you for final thoughts, but I really want to say thanks for coming in and having the courage to talk about your story
Of course.
in front of television, in front of all these people. So first of all, final thoughts.
I had to think about whether to come on here, but I felt like if there was somebody out there that was asking questions or a little nervous about this, if hearing what I had to say made a difference. I wanted to make sure they heard it. So,
Well, thank you for doing that. That's awesome. Dr. Kilgore?
Yeah, I would just first of all thank Lisa as well. It's really stressful for patients when they have a strong family history. They may or may not have a mutation, and so I think for patients that are wondering, am I the right candidate for this? What do I want to do? I have no idea, is really getting a full evaluation. Let us walk you through it. It's stressful, it's overwhelming, and what's right for Lisa or someone else may not be right for you either. So have a consultation with us. We can help you along the way, figure out what's best for you, for your risk reduction and prevention of breast cancer.
Dr. Nye?
I'm going to echo what Lisa said. Knowledge is power is the motto in my clinic. And if you have a genetic mutation, you were born with it, it's there. So if we know about it, we can at least take steps to minimize your risk. And here we have an amazing team. I get to work with my surgeons as well as other high-risk providers and offer excellent care to lead to early detection and reduce cancer risk.
It is amazing stuff. All right, Doc Hawk.
Yeah, remarkable show, remarkable guest. All those final comments were so on point. I agree with all of them. And as far as infections go, there is still time to get your vaccines if you haven't yet. RSV, as we heard Dr. Stites, if you fall into that category, the age group, 60 and over, still time to get updated COVID vaccine and influenza vaccine, and unfortunately we are just seeing more influenza circulating around the community and around the country now as well.
This has been a remarkable program, and special thanks to all of our guests and to Dr. McGurk, who has headed out, obviously. We talk a lot on here about the miracle of faith, hope, and science, and we are in a new age of medicine. And you realize the very first topic and this topic really focused on the importance of genes and how we can do things to help avoid disease, mastectomy, or we can also now alter genes, sickle cell therapy. This is an amazing age of medicine. Stay tuned to this program because we're going to keep you up to date on all the changes that are about to come, because this is going to be a great, great ride. Live long and prosper.
A Christmas miracle for a retired nurse. I'm Alexis Del Cid. On the next All Things Heart, Archie Moore joins us as the one-year anniversary of getting her new heart approaches. How she's celebrating Christmas this year with her 13 grandbabies.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.